Globally, mental health has a crucial impact on all ages. Coming up next, we have a panel of 4 who will be discussing the global perspective of mental health. Dr. Mathew Varghese, who will be chairing this panel, was associated with NIMHANS for more than 20 years in various important positions. He developed the family intervention programs for schizophrenia and dementia. He retired as a senior professor of psychiatry at NIMHANS in 2021. Currently, he is holding the post of adjunct professor in St. John's Medical College, Bangalore, India. Joining him as his panel members are Dr. Somnath Chatterji. He is a psychiatrist responsible for SAGE, which is WHO's study on global aging and adult health. He has worked with WHO for over 20 years and has held several important positions. He has contributed to several crucial WHO flagship reports, including World Report on Aging and Health in 2015. Dr. Kapur Shankardass is a sociologist, gerontologist, health social scientist, international consultant, and retired senior faculty at the University of Delhi. Dr. Josefine Antoniades is a PhD, a research fellow at NARI in the Division of Social Gerontology and an affiliate at Monash University, Division of Global and World Women's Health. She was a part of a comprehensive scoping review about older people's mental health and well-being in Australia, a study commissioned by the Australian National Mental Health Commission. Her current work is focused on culture, aging, and dementia, mental health non-clinical. Please join me in welcoming Dr. Mathew Varghese, Dr. Somnath Chatterji, Dr. Kapur Shankardass, and Dr. Josefine Antoniades.
Good evening, everybody in India, and late night in Australia. Thanks, Joe, for joining in. So it's very late for you. And good morning in other parts of the world. I think it's afternoon for Somnath. First of all, I'd like to thank YILAGA and Dr. Sally Chacko for having us do this panel to talk about global perspectives on mental health and aging. And I would also like to thank my panelists, Somnath, Mala, and Joe, who have been introduced and who very readily agreed to join in this panel discussion. As you have heard, all 3 of them are very distinguished people researching these aspects of mental health, especially with regard to the issue of aging. All of us know that mental health is a very important component of human life. And I think that has been exemplified in the last 2 years with the COVID pandemic. And we all know, we've read, we've seen, we've experienced how older people in our own families have been affected, have experienced this problem. And maybe one of the flip sides or plus points in this whole pandemic in the last 2.5 years is that mental health is now finally being given the prominence that we mental health professionals think it should have deserved way back. Because the old adage, no health without mental health, is something that is so very prominent at this point of time. Many countries have had projects on aging, and Somnath is very familiar with them because he was responsible for one of the first reports of the WHO on aging and health. We ourselves have in our country the longitudinal aging study of India, which has thrown up a lot of issues, which I will bring in the discussion in the next few minutes. But I will first ask each of my panelists to give a brief talk about their perspectives about global issues with regard to aging and mental health. So I'll start with Somnath and go over to Mala and then on to Joe. And then we'll come back again and do some question and answers around the table. Somnath, over to you.
Thanks very much, Mathew, and thanks, Sally, for inviting me to this meeting. I'll start where actually Sneha began, that this is a session about the individual and the environment, right? Now, why does that matter? Because we define healthy aging as the ability of older adults to be able to do the things they value in their real world environment, right? And this is essentially the outcome of an interaction between an individual's health and the environment they live in. What I plan to do in the next 5 minutes is to just give you a quick idea of the kind of work that I personally have been engaged in and on behalf of the World Health Organization. Give you some highlights of what I think are our main findings, which highlight the importance of mental health in the context of this panel, and what can we do about this, and why it matters. Besides what Mathew already highlighted, that in the course of the COVID pandemic, we have seen why mental health has become a very prominent issue. So our studies on global aging and adult health is essentially a set of studies, a longitudinal cohort of about 45,000 people in 6 countries, including in India, who we've been following for the last 15 years. And much of the insights that I'm going to talk about are essentially gained from that study, besides a range of other studies that we have been sort of doing in Europe and elsewhere. So to emphasize, as you probably all of you are aware, I don't need to belabor this point with this audience, that aging is an issue not really of the high-income countries. In fact, already a majority of the older adults live in low and middle-income countries. And clearly, the health systems in low and middle-income countries are just not prepared for this. They haven't been prepared, they're not prepared now, and they won't be prepared for the future. It's already too late, but I hope that health systems around the world will respond to this at least now. Because at least a fifth of older adults suffer from what we call multimorbidity, which means they have multiple illnesses. So it's not a single illness. And often there is a comorbidity between physical and mental illnesses. Now, what that really means is the services that the health system needs to provide for older adults essentially needs to be a model where you provide integrated, people-centered health services. Because, as I said, not only do physical and mental disorders coexist in older adults, but it is actually the coexistence of this that actually produces the worst impact on health. In other words, if a person has diabetes and then has depression in addition, it has a much, much more severe impact on that person's health than either of those two conditions alone. Now, that clearly has implications, because what often tends to happen when an older adult visits his healthcare provider, the person often detects the physical illness and perhaps manages the physical illness, but fails to detect the accompanying mental illness and fails to intervene, which means you never really provide that person with the services that person needs. And of course, as people grow older with age, these comorbidities, as well as the impact of the mental health condition, actually worsens in older age, right? So we had often thought, and it was actually a myth, if you look at the literature about 2 decades ago, that mental illnesses or mental disorders are actually a problem of the young. But we clearly demonstrate that many of these mental health conditions actually worsen with older age. And the impact of those conditions actually worsens as people grow older. And it's not just about mental disorders, right? Because this panel is also supposed to be about mental health. So mental health, of course, is not merely the absence of mental disorders, but what we refer to as subjective well-being. So what we also show is that unlike in the West, in most high-income economies, what you find is typically subjective well-being follows a U-shaped pattern, right? So when people are beginning to work or they are younger, their subjective well-being is at its peak. When they have a whole bunch of responsibilities at home, the well-being actually drops during midlife, and then it picks up again in older ages. But in low resource settings, that is not the case. Actually, subjective well-being tends to decline continuously over the course of the lifespan. And in addition to the decline in subjective well-being, there is an increase in loneliness. And of course, the COVID pandemic has highlighted, what has been now called the epidemic of loneliness. And once again, this is not just a problem. We had believed that, in our kind of settings, we had large families, we had joint families, so people wouldn't feel lonely and they had a big social network. But that's clearly changing. Right? Single person families, even in countries like India, is on a dramatic rise. And this is not just in urban settings, but also in the rural part of the country as well, which means people are increasingly becoming lonely. Their social connectedness, their social networks are on the decline. Now, why does this matter? Because subjective well-being is one of the strongest predictors of future mortality, right? And there are things that can be done to improve the quality of a person's life in terms of their subjective well-being by changing the time use pattern of older adults. And that's an eminently doable intervention, which really doesn't cost much because we actually know the kind of activities that people engage in, which is associated with negative emotions and misery. Finally, what I want to say is that, of course, all this doesn't happen equally in every single individual, right? So there are very clear inequalities that exist in terms of education, in terms of income status, in terms of rural urban distributions. Often all these health outcomes, all the well-being outcomes are worse amongst the poor, worse amongst the people who are less educated, and worse in rural areas. So, and finally, we are now in a phase where we can actually predict the way people will age. So if you start at a certain point in time, as I said, everybody doesn't age the same way. But it's possible for us now to actually predict the kind of groups the person will belong to. And that is the time to intervene. So it's the preventive and promotive interventions that will actually alter the trajectory of the way people age. And as I said, the time to act is now. And if we don't do it now, I think it'll already be too late. Thanks very much, Matthew.
Thanks. I had some issues, so I just shift to other place. For issue, because I think it would come out turn to about the issues of gender with regard to all these issues, because I think the issue that Somnath mentioned
Thank you. Before I share my preliminary thoughts on the topic of global perspective on mental health and aging, and stress on the need to consider gender aspects in our discourse, I want to, at the outset, state I'm pleased at having the opportunity to be a panelist for this important topic and glad to be amidst experts whose work I value. I now come straight to the issue of the need to pay attention to gender dimensions with regard to mental health and aging. It is important for us to realize that as few studies since some time are also indicating that the life course timing in the onset, type, and expression of mental illnesses follows sex and gender-specific patterning. This is seen in a number of mental health disorders, such as Alzheimer's disease, depression, anxiety, schizophrenia, and even in the case of substance abuse. Understanding the gender specificity of mental health issues is pertinent as it reflects how the care provisions in societies are channelized with implications for the affected individual, for societal responses in developing care services, for assessing the social and economic burden of care at the micro and macro level, for analyzing the strain on families, for the kind of responses that are generated in policies, and what kind of costs it entails to the society as a whole. If we look at the global projections being made for mental illnesses, the number of those with dementia will double in the next 2 decades, and the proportion of women is being estimated to be higher because of feminization of aging taking place in almost all countries. In addition, this demographic reality of aging societies is also being projected to be the cause of late life depressive disorders, with higher proportions of women affected. Further, as prevalent studies world over are indicating, mental health issues are leading cause of disability in later years, with higher proportion of older women and specifically widows being affected, and who in most societies belong to the most vulnerable segment of the population. This dimension becomes critically pivotal in our concern for developing services having appropriate care mechanisms in societies. It also pertinently places the need to have adequate provisions for long-term care facilities, both at the community and institutional level from a gender perspective. We must reflect on why looking at things from a gender lens is also imperative. It is because world over, studies are indicating that mental health and well-being of older men and women are influenced by varying personal characteristics, cultural factors, family constructs, and national policies and resources where gender considerations are kept to the minimum. And thus we see gaps in met and unmet needs. Therefore, the point I want to bring to attention to in this symposium is that in understanding issues related to aging and mental health from a global perspective, gender dimensions should not be overlooked or ignored. And when we discuss the status of aging and mental health, including its prevalence, caregiving provisions, policies and services to address the concerns, no matter in whichever country it may be, in any region of the world, we must pay attention to the needs and appropriateness of our responses as these cater to older men and women, along with paying attention to other heterogeneous characteristics of the aging populations. I will stop here, but would like to come again to highlight how we should develop effective approaches to address geriatric mental health issues for women, specifically whose needs are often ignored. Thank you.
Thanks, Mala. Thanks for emphasizing the issue of being a woman and the important issue of gender. And we will indeed come back to what needs to be done to address this imbalance. We'll now go to Josefine. And Josefine, I'm sure will talk about some issues of healthcare utilization and also ageism. But if she doesn't, I will ask her about this later. Jo, please.
Okay. Thank you. And thank you. I want to just chime in with Mila, and thank you very much for inviting me onto this panel. I'm very excited to see you all and be able to sort of share my thoughts with you. So as mentioned, I have recently been part of a large scoping study to understand what mental health means to older Australians. And as part of that study, we sort of tried to identify what key issues stood out and what's important for them, both in terms of prevention of mental health issues and also what needs to be done or what people felt needs to be done to better support people who actually live with mental illnesses. And as part of that activity, the study was a very quick but very intense study. So we did a large systematic review of interventions. We did a policy review of all Australian mental health policies as far as we could find. And we interviewed and ran focus groups with people who have a lived experience of mental illness, older people, carers, policymakers and service providers across Australia, we tried to sample both cultural diversity, different sexualities, gender, all those sort of things we tried to incorporate. And what really stood out to me, because I've looked at a lot of the data, and particularly stories from older people, whether or not they had mental health problems, was the issue that anyone who has more than 65 candles in their birthday cake face in Australia, and I'm sure also overseas, is ageism. And as part of that, ageism came across as a cross-cutting issue that really impacted on older person's mental health, and in ways that were both on a personal level, where people, it impacted their ability to work. And that what you were saying, Somnath, was, we want to support people to do the things that they value in life. However, a lot of the older people we spoke to were not able to continue doing the things they valued in life, which was work, which was engaging in the activities that they wanted to engage with. And for many, and also Mala, there's just so many intersectionalities here with the gender issues as well. Women often were left behind and faced more ageism in the workplace. Even though they wanted to continue working, they were highly educated, they couldn't. And so that really caused them a lot of psychological distress. The other thing that we found as part of our review was that there's structural ageism, where older people are not meaningfully included in policies around mental health. They're mentioned, but they're just stuck into a bucket of vulnerable communities. Anyone over 65, but as you mentioned, Somnath, each person ages differently. You can't say, okay, well, I'm going to age just like my brother will, or like my neighbor will. We all have different abilities. We face different challenges in life. But yet older people in policies are often just mentioned as older people. So that was problematic. They weren't meaningfully included. Funding, similarly, not receiving the same amount of funding as, for example, younger people. And while we live in Australia, we have good mental health services. Many people, including providers, said it was much harder for older people to engage with mental health services, partly because there's a lot of stigma around mental health. still, especially in the older generation. But also partly because services just weren't set up for it. They weren't set up for dealing with the issues that older people face. It's like, have a cup of tea, you'll be all right. It's okay, you're just getting older. You know, everybody has a little bit of depression, a little bit of this and that. So I think ageism is really one of the issues that we need to consider if we want to meaningfully actually ensure older people's mental health and well-being. And as you say, actually prevent distress. And help people live meaningful lives as long as possible. I have many friends who are, you know, over 65, and they are much more productive than I am. So really let people live the lives that they want and value and contribute to society in ways they would like to contribute. So that was sort of my little spiel.
Thanks, Joe. I'm just looking at the time, and I'm aware that we have about 15 minutes left because we had to finish about 20 past 7 in India. So I'm just going to ask the three of you to respond to each other's questions or queries. And Somnath, first of all, just want to underline this issue that you said about multi-morbidity and make the general public aware that if you have depression and you have, say, diabetes or hypertension, that means you're going to do worse with regard to your diabetes and hypertension. Or if you have diabetes and hypertension, you might be more susceptible to develop depression or maybe cognitive disturbance. So there is an interplay, and I think Somnath emphasized this whole issue of the interplay. But the important part, which he also said, is that even in places like the Western world, more so in the Islamic regions, most people are not diagnosed. The hypertension, diabetes, depression, forget depression, hypertension, diabetes are not detected. And even if they are on treatment, treatment is not continued. So what are the choices, Somnath, with regard to aging well and being healthy aging? I know WHO has declared, UN has declared it as the decade of aging. So what really will help in terms of intervention so that people can age well?
Yeah, so I would say two things, right? One is, as I said, you know, health services cannot be siloed in older adults. It shouldn't be siloed anywhere, but even more so for older adults, simply because of the reason that you just elaborated, which also means that we need to sensitize the healthcare providers to at least look for common mental disorders, right? And intervene with those common mental disorders as much as they would intervene with the physical disorders as well, because that is the only way to actually produce the optimum outcome and not have the person being shunted from one place to the other. The second thing I would say is really the other sort of interventions that we need to provide to improve subjective well-being and reduce loneliness. And what I mean by that is, as I alluded to, I think there are very clear interventions that one can actually provide to improve the time use of older adults. Because what we do see very clearly in our studies is that as people grow older, the repertoire of activities they engage in tends to shrink. And that shrinking of the repertoire actually leads to declines in subjective well-being and increases in loneliness. So I think there are several interventions that have been tried to actually increase the social connectedness of older adults and improve the quality of time use that older adults have. I mean, there are many such examples, right? I mean, whether it's to do with volunteering, whether it's to become actively part of other social groups, whether it's environmental modifications to enable older people to go out and, you know, so be in parks or, sort of even simple interventions like providing social benches. So there are many such interventions which are actually cost effective, which I think we need to engage in.
Yeah, thanks, Somnath. I have this fantasy that if we were to do primary prevention, in the sense that, because after all, the risk factors for health and mental health are really common. There are about 12 or 15 common risk factors which impact everybody. And that's the same for young and old. I have a kind of fantasy that, if you were to do mass public education about these risk factors and get people to help them to go for intervention and get them to intervene, that might help a lot. You think that's something that's possible? Because when you do mass education, and if people were to actually reach out and do self-care, all of us are familiar with the WHO pyramid, where self-care is really something that is very important. And we saw that to a large extent during COVID, because during COVID, there was so much of education and so much of awareness that everybody did things for themselves. They might have overdone things, but you think that's a solution to this whole problem? Because you said that health services are never going to be able to pick up.
Yeah. So my pet peeve here actually is that I think if we have to deliver interventions at scale, I don't think it can be done by people. I think we have to actually harness the power of digital technologies, and coupled with the use of digital technologies, actually use behavioral insights. Because I think one of the biggest problems we have is, first, besides the detection piece, is I think adherence and compliance. And if a person has to be nudged into self-care and adherence, I think the only way to do that, in my view, is to harness the power of digital technologies and use behavioral insights to do this.
Yes. Together with that, doing it in a very large way, I guess you also need policy and programs for the government. Isn't again something that we saw during the COVID, that unless you have a policy, and I think Joe is somebody who's done some work on this, looking at policies and how policies might actually impact whether people, whether you can pick up people who have disease, or whether people will actually go for help, or people will seek help themselves.
Can I make a comment on digital health? So that's, as you know, Matthew, that's one of the areas we work a little bit in terms of more health promotion around dementia, but and supporting carers of people living with dementia. But so we work with cultural and linguistically diverse communities here in Australia. And the problem is with digital health is sometimes older people are just not digitally literate. So, that's a real barrier in terms of using digital health strategies. So, it has to be a multi-pronged, I suppose, approach where, people are first upskilled to use those facilities, and also then being able to recognize the importance of mental health. Not everybody wants to talk about mental health, so it may have to be wrapped as something different, well-being or, something. So yeah, that was just a comment that I just want to put out there, especially talking about other people. Yeah, so I think, once I'm 65, hopefully I'll just be able to click a button and I'll be happy and it'll be fine. But
yeah. So anyway, to what Somnath said, I think Britain is the only country which has got a minister for loneliness, I believe. Yeah. So Mala, what are your thoughts on how to address this imbalance? And it's really an imbalance because, as we all know, older women are more prone to have anxiety and depression. Older men are more prone to have heart disease and strokes. But if older women were to get them, they would actually die as a result of that, while the men might actually survive. Alcohol and substance use is much more common among the older men. That's much less, at least in our country, among the women. So how do we address this? I mean, women are living longer. There'll be more women who are older than men, even in our country. So what are your ideas about how we're going to address this?
Yeah, thank you, Mathew. It's an important question, and I feel that for addressing geriatric mental health issues for women, the need of the hour is to increase awareness on mental health concerns for women. I mean, we have in societies a total neglect of emphasis on women's health, and very little is being done in terms of policy interventions. And we have to focus on capacity building for care providers to take into account the specific needs of older women. We need to strengthen training and research activities related to older women. There is still not enough understanding about what are women's diseases, what are women's health concerns, what are their various kinds, and why they get into depression and so forth. And we need to develop community-based rehab programs. I mean, in many communities, we don't find provisions for women. I mean, even to the extent that where we find in some developing countries, senior citizens associations have come up where senior citizens community centers have come up, but recreational needs for women are quite limited. So the emphasis on women's health, including mental health, is very limited and is low. So we need to develop a very holistic primary health care and community care system, which is very gender centric. And also the fact that there is always reluctance in many societies to seek treatment for mental health disorders. And this is more so among women because I think right from a young age, culturally, especially in the Asian societies, we find that their health needs are not given importance. Forget about mental health, even physical needs are not given importance. So we have to find out how to encourage women to come forward and seek treatment for them. And also, I think a lot of health professionals are discovering that treating women requires a different approach than is used to treat men for the same illnesses. And it is being seen that women experience symptoms in quite a different way from men. But at the same time, they are ashamed to seek help for mental disorder. And they don't even, they are not even rather aware that their symptoms can constitute an illness which needs treatment. I mean, they're so used to living with their health handicaps that they don't even see it. And this is something which is coming through even in the LASI study of India, which is a large study of at the national level. And it has also, I think even Somnath would probably find that in the SAID study, responses by women and for women is quite limited. And I think we need to take a step towards having more provisions for diagnosis and treatment for mental health conditions for women. And one of the things where you pointed out yourself is to improve education, provide more information about the prevalence of mental health illnesses, discuss the negative effects it has on women and families, and sort of give more emphasis on treating women because of their any health needs and so forth. I'll stop
Thanks,
here.
Mala. Yeah, I'm sorry for cutting in because I find that we have exactly 2 minutes left.
Yeah.
So any quick thoughts from any of you all, anything which you have not mentioned, because all of you have emphasized on the issue of large-scale interventions, rather public, making digital health and scaling up, looking at old people in a different way compared to other people, meaning addressing their problems specifically, and then of course looking at the gender disparities and looking at them differently. So any quick last thoughts from any of you? Somnath? Or Joe? You're muted, Somnath.
Yes, I mean, one thing I would like to, it's interesting to hear Mala speak, because in Australia, women are more likely to seek help. Not that they do enough, and there's just so many interesting issues I'd love to discuss with you. But anyway, but I think another important issue is to consider that not everybody reacts in the same way to interventions. So it's really important to also tailor interventions to the individual, because otherwise they're not going to be impactful if it's just a large scale, cookie cutter approach. I think that doesn't work either.
Yeah, thanks, Joe. Somnath, you were saying something. Final words. Yeah, now you're unmuted. Muted again. You're muted again. Yeah.
Yes, it was being automatically muted. But yes, so I think just following up on the gender issue, I think consistently we show that women have worse health outcomes than men, right through the lifespan, which is sort of what we refer to as the gender paradox, right? Because women live longer, and yet they spend a much larger proportion of their life in poorer health, and that is in and of itself a challenge. But more specifically with older women, I think the two issues which strike me are, typically we have believed that women have a larger social network and they're more socially connected than men. But that doesn't seem to be true, at least in relatively low resource settings, at least in our studies. We don't see that, because that is supposed to provide some sort of a protective effect for women as they grow older, but we don't seem to see that. And secondly, the caregiving burden, I think, is substantially more in older women than in men, which also therefore has a big impact on their time use and therefore their subjective well-being. Both of those things, I think, need to be addressed.
Thanks very much, Somnath. And thank you very, very much to Somnath, Mala, and Joe, especially Joe, for whom it's almost time to sleep. And thanks very much to YILAGA and Sally for having us on this panel. It was a very interesting discussion, and I think we've just exceeded by about a minute or two. So back to you, Neha. Okay, thank you.
Thank you, Dr. Mathew, Dr. Somnath, Dr. Mala, and Dr. Josefine for bringing to the forefront the multitude of factors that affect one's mental health.